Hello and welcome to the Waldenstrom's macroglobulinemia update. My name is Daniel Zlatin. I'm with the Waldenstrom Macroglobulinemia Foundation of Canada. The session here is about to start, and just I'll go over a couple technical items before we get going. Just so you know, the session will be recorded for future availability off of the Waldenstrom Macroglobulinemia website. You'll see several windows on your display. You can change the size of any of those. To return to the display to the default configuration, just click on the leftmost circle. You'll see at the bottom of your screen. And to access the panel for submitting questions, click on the circle second from the right. And for those of you who are not aware, we are most privileged that Dr. Stephen Treon with the Bing Center for Waldenstroms, an eminent Waldenstrom researcher, has been able to step in after we had some scheduling problems with Dr. Castillo. And now I'll hand this over to Cam Fraser, the chair of the WMFC.
Thank you, Daniel. I am thrilled with the number of and the participation of people in today's event. This is the third and last of our ground round. We've held two previous ones, one in the Vancouver or the West Coast time zone and another in the East Coast one. So this will be the third and the last of this ground round session. The event has been sponsored by the WMFC, but we have to say that we've had a great deal of support from Beijing, Canada through an education grant that have made this event possible. The WMFC that's easy for me to say, is an entirely volunteer foundation dedicated to the patient support, education, and research to find a cure for WM. We are a sole, we exclusively work with WM patients and WM medical clinicians, and we are not diverse beyond that type of direction, I guess. So our mission is patient support, education, and research for a cure for WM. Patient support, trying to find another WM patient to talk to and share ideas with or side effects of the diseases is very difficult. So what we have done is we have established support groups right across Canada in 9 major cities, from Victoria all the way to Halifax. We normally hold in-person meetings, but due to COVID, unfortunately, like a lot of events, they've been canceled and they're now solely on Zoom, hoping to return to in-person by this fall. Education is divided into 2 parts. One is patient education, where we hold an education forum every year somewhere in Canada, usually in major cities, and we usually go east or west. Unfortunately, the 2022 education forum has had to be canceled. It was going to be held in Calgary, but it's been canceled because of COVID. In addition to that, we also have a website that Daniel actually maintains, and it's extremely up-to-date, very useful, has lots of information on it. And if you have questions about WM, by all means, please take a boo at the WMFC website. Education is built into 2 components. One, the last part is research. And research, we spend 80% of all donations on research. Most recently, we went with Dr. Hunter of the Bing Center of Dana-Farber, and we funded one of his research projects in the tune of $200,000 US for over a 2-year period or 2.5-year period. That particular research project will conclude at the end of this year, and we're extremely pleased with the results thus far and are very optimistic of what Dr. Hunter will come up with. What we'd like to do is to make sure that when you're dealing, if you're in the medical community, please talk to your patients and advise them of the existence of WMFC.ca, which is our website, to come on, and we'll be able to contact you directly with any questions and to become a member of the organization. Now, as with you've heard enough about that, Professor Treon, I suspect, doesn't need much of an introduction. He is currently the director of the Bing Center for WM within the Dana-Farber Cancer Institute in Boston. He is also a professor of medicine at Harvard Medical School. Professor Treon and the Bing Center and Dana-Farber Cancer Institute have combined to make significant advancements in the treatment of WM. Through his research and literally seeing hundreds of WM patients, I wish there were that many, I guess, maybe, hundreds of WM patients, he offers a wealth of experience in treating of this disease. They are also strong supporters of the International WM Foundation in the United States, the IWMF, as well as the WMFC here in Canada. Professor Treon is very active on the WM board, which I'm honored, Stephen Treon.
Thank you so much, Kim. I think that was an introduction, a wonderful introduction, and I appreciate so much your kind comments. I will say, just before I get started, I'm grateful to the WMFC and to Baijin for making this program possible, and in particular to the WMFC for having funded Dr. Hunter's work. Dr. Hunter is a phenomenal genomics doctor. I think he's one of the top talent we have at Harvard. And it's through his prowess that we've made all these incredible advances in understanding the genomics. You'll hear about them tonight. But I will tell you, I'm privy to work with him and privy to be able to see his work. And I'll tell you, he is shedding through your funding so many new insights now into the pathogenesis of Waldenstrom's. And I think with this, we have the opportunity to further innovate in terms of treatment advances. So let me begin off by sharing, first of all, my disclosures, and then to give you at least some of the open questions that I'm hoping to address in tonight's program. And these are open questions that exist no matter what meeting I go to. These are the points that people want some clarity on. And fortunately, there's more and more data now to help us with this. But let's frame these, because I think as I present the data to you tonight, we'll be able to draw some conclusions. So the first is, when do we use chemoimmunotherapy, rituximab-based therapy, versus BTK inhibitors? We'll talk a lot about BTK inhibitors. Which BTK inhibitor and for which patient? Now we're blessed to actually have several BTK inhibitors. Management of those who become intolerant or resistant to BTK inhibitors. Big question, because now a lot of patients are on BTK inhibitors. How do you manage them when they just can't tolerate or have acquired resistance? And then lastly, what's the role of genomics in treatment decision-making? So I think those are all, at this point, the key questions that are out there. And let's look at the data. To remind the audience, Waldenstrom's can present many different ways. For most patients, it involves infiltration of the bone marrow, which can lead to cytopenias, anemia, thrombocytopenia, leukopenia. But I think it's also important to remember that the IgM secreted by these Waldenstrom cells can also cause problems. Hyperviscosity syndrome, it can attach to the red blood cells and cause cold agglutinemia. It can precipitate and form cryoglobulins, and it can also attack the myelin sheath of the nerves. And I think it's also important to remind the audience that at time of diagnosis, it's rare that you see enlarged lymph nodes or spleen, more common at relapse. So you start thinking of this disease more like a lymphoma. And also, these days we're plagued with increasing numbers of patients whose disease relapses in the central nervous system. We call this Bing-Neal syndrome. And here too, there's been a lot of innovation using BTK inhibitors to treat Bing-Neal syndrome. Now, just to remind all, chemoimmunotherapy has had its success, especially in the era that we've combined rituximab with proteasome inhibitors and with bendamustine. We've gotten much higher response rates than rituximab alone, but still complete remissions are fairly elusive. So the one thing I would just make sure the audience understands is that the goal of therapy is not to get a patient into a complete remission, because sometimes people push hard, clinicians push hard, and all we see is toxicity. Really the prowess of therapy is to try to alleviate symptoms and key manifestations of disease, and ideally to try to get patients into major responses, because these do translate into long-term progression-free survival, but not to keep switching regimens in the hope that you're going to be able to get the patient into a CR, because that's very, very unusual. And I see that a lot, where patients are sometimes, taken off of one regimen onto the other, even though they've responded. But the intent of the clinician there would have been to try to get to a CR. It is very unusual to have that happen. Now, some of the treatments that we use can have a lot of toxicities. Rituximab can cause the IgM flare. When the IgM goes up, it can aggravate things like the viscosity. So you can throw somebody into a hyperviscosity crisis. If they have IgM-related neuropathy, you can make that worse. Cold agglutinins make that worse. Cryoglobulins make that worse. Also, with prolonged use of rituximab, you can actually deplete the good B cells and make the patient hypogamma-globulinic. And then also for some patients, actually the repeated use of rituximab can lead to an allergy intolerance. Fludarabine used to be a drug that we used to use a lot, except that what we saw with this was transformation of disease to aggressive lymphoma. With bendamustine, which we use a lot, and I know in Canada you do, we've sort of backpedaled a little bit. We don't use 6 cycles. We tend to use 4. There's been studies by both our institution and the Mayo showing that 4 can be as good as 6. And what you're doing is you're dialing down these prolonged cytopenias that we see with 6 cycles. And also, we do see a small risk of acute leukemia and MDS. And by dialing down the number of cycles, perhaps we're impacting this risk as well. And bortezomib, which I think all of you know can cause neuropathy. In Waldenstrom's, we tend to see a lot of neuropathy and even a high discontinuation rate. So because of all these reasons, it's been important to try to innovate with therapy. And this big break to terms of innovating therapy in Waldenstrom's came with the discovery of the key mutation in this disease, which involves MYD88. This was discovered in my laboratory, and 95 to 97% of patients actually carry this mutation. Almost always it's this L265P mutation, where leucine becomes proline at position 265 in MYD88. Now, proline is a big rigid amino acid, so it actually distorts the contour and function of a protein. So that's why when you see a proline substitution, it means something. And over the last decade, we've been deciphering what exactly these MYD88 mutations do. These are part of the toll receptor pathway. Toll receptor sense for various pathogens. And here, when you acquire the mutation in MYD88, you end up causing a lot of havoc. All these signaling paths are turned on. Importantly, HCK, which is a SARC family member, is actually overtranscribed. Normally it's silent. This shouldn't exist in a late stage B cell. But once HCK becomes transcribed in response to mutated MYD88 signaling, this then turns on BTK, which is why we're going to talk about BTK inhibitors. But it also turns on other pathways. ERK, which causes cytokines to be released, inflammatory cytokines, which actually affect, the microenvironment. They affect immune cells. And also it turns on the BCR pathway. This was a recent discovery by us, enabling yet further pro-survival signaling. So I think what you come away with understanding is what an incredible molecule MYD88 is, in the sense that it can turn on a lot of pro-survival signaling. But also you see here therapeutic opportunity. A lot of these molecules can be drugged. In fact, these days we're working on developing directly HCK inhibitors, and we've been successful. In Blood last year, we published a very nice paper on KIN8194 that's an inhibitor of HCK. Tonight, however, I'm going to focus a lot on BTK. Before I go there, I also want to tell you about a second mutation, and that involves CXCR4. We see this mutation up to 40% of Waldenstrom patients. It was also discovered in my laboratory thanks to Dr. Hunter. And this is why I think, your investment in Dr. Hunter is a good one. Dr. Hunter actually redesigned all the algorithms to analyze whole genome sequencing. And it's because of his computational skills we were able to find these mutations. They occur usually here in the C-terminal domain. And what happens is CXCR4 is a receptor. It actually traffics cells to the bone marrow in response to CXCL12 that's made by the bone marrow stroma. So when you acquire a mutation here in the C-terminal domain, this is a regulatory domain. So by affecting this area, you're affecting the ability to shut down this pro-survival signaling. Now, CXCR4 mutations come in two different flavors. There's the so-called nonsense variants. This is when you introduce a stop codon. When you introduce a stop codon, then this part of the protein doesn't get coded. And then there's frame shift mutations, which occur because of insertions or deletions of DNA, which scramble the genetic code. By messing up this area, you no longer get proteins called arrestins that can come in and bind and shut down the signaling, so CXCR4 signaling goes unimpeded. These nonsense variants, the prototype is the serine 338X mutation. X means a stop codon replaced it, are the most common. And these are the ones associated with hyperviscosity syndrome. So if you see a patient coming in with very high IgM levels, most likely they have a CXCR4 nonsense variant. Now, just to tell you, one of the reasons why we're excited about the discovery of this mutation is because you can actually do something about it. There's drugs like plerixafor and ulocuplimab, which I'll talk to you about later, which we can use to block CXCR4 signaling. And that's important because the modeling that we and others have done shows that the signaling pathway is very important for mediating resistance against ibrutinib and, as you'll learn, also other BTK inhibitors. And so if you use a drug that can block this interaction of CXCL12 made by the bone marrow stroma and CXCR4, you can actually sensitize cells to ibrutinib. And that's what we're trying to do in some of the clinical trials that we're currently running. Now, sometimes it can be difficult to find these mutations. So if you're looking for the MYD88 mutation, go use PCR. It's very, very sensitive. You can pick up even minute amounts of disease. But a lot of clinical laboratories use next generation sequencing, NGS, and some of the earlier platforms can miss the MYD88 mutation quite commonly. In fact, in this study that we did, 1 out of 3 patients was missed, particularly those that had low bone marrow involvement. If you're thinking about CXCR4, it's even worse. Next generation sequencing might miss 2 out of 3 patients, particularly those that have low bone marrow involvement. Some of the newer platforms that use bidirectional sequencing and molecular barcoding seem to be more reliable, and that's been our experience. We've actually adopted those sort of platforms, and we're picking these up now. So with this sort of background, we were very excited to evaluate BTK inhibitors in Waldenstrom's, and in fact, I chaired this study looking at ibrutinib in previously treated Waldenstrom patients. This is now known as the pivotal trial because this permitted approval of ibrutinib in the US and then Europe and Canada and other places. And it became the first drug ever approved for treating Waldenstrom's because of this study. It was originally published in the New England Journal of Medicine. This was our happy day in June of 2014 when we met with the FDA and provided our data to them. And this was an investigator-led trial. So we were very proud that we were actually able to take our data to the FDA and have the FDA, approve this drug. What you see here is the characteristics of the patients in this study. They were very sick. On average, they had 2 prior therapies. Some had out to 9. 40% were refractory, meaning they didn't respond to their last therapy. So with this in mind, we were keen to do the trial. What did we learn? We learned that ibrutinib is a very active drug. In fact, 90% of the patients had at least a minor response, 80% had a major response. Major response means at least a 50% reduction in disease burden. You'll also hear me talking about VGPRs, or very good partial responses. This is a 90% reduction in disease burden measured by IgM. 30% got there. And what we saw with the follow-up that we published in JCO, in the Journal of Clinical Oncology, is that the genomics played a big role. If the patient only had the MYD88 mutation, look, almost everybody was a major responder. Half were a VGPR responder. If they had both mutations, you see that the major response rate went down. There were far fewer VGPRs, and major responses took longer to get to. And if the patient had no MYD88 mutation, we call that wild type. If they have no MYD88 mutation, no major responses. And so you see how important the genomics are in terms of getting a response. This is also true when you look at how long these responses last. In fact, the patients that had only the MYD88 mutation, at 5 years, 70% had not progressed. Their disease was still in check. If they had both, it was 38%. If they did not have a MYD88 mutation, this occurred much, much quicker. So genomics played a big role in terms of predicting outcome. Now, what we learned with the longer follow-up is that more patients had atrial fibrillation, so 13% had heart arrhythmia. But most of these patients continued on, drug on ibrutinib with medical management. So that could have, entailed either being put on an antiarrhythmic drug or an anticoagulant to thin out the blood, or had cardiac ablation. But it involved some sort of medical management. We also published very recently an update of our trial giving ibrutinib to patients in the first line, meaning treatment-naive patients. These were all MYD88 mutated patients. Major response rate was 87%. There were fewer of those VGPRs and fewer of those major responses if the patient had the CXCR4 mutation. And look here, this is really important. It took 7 months on average to get to a major response if you had the CXCR4 mutation, versus 1.8 months if you didn't have a CXCR4 mutation. So this is important clinically because sometimes, you need to get a patient to a response. CXCR4 mutated patients, many of them have hyperviscosity crisis, right? This is why knowing somebody's genomics, and John here asked a question about, does it make a difference? It does make a difference to know the genomics, because then you can sort of plan out what therapy should I be using. So absolutely, John, I would highly encourage, doctors and patients to make sure they know their MYD88 and CXCR4 mutation status. I also want to point out here that when we looked at, how long these responses lasted, look here. At 4 years, 92% had no progression of their disease if they had no CXCR4 mutation. They were wild type. If they had the CXCR4 mutation, it was 59% were still, holding on, meaning that they didn't progress. So again, a difference here based on CXCR4. We did learn in this trial something else also, which is important, for all of you to know, both patients and physicians on the call tonight, clinicians. And that is that if you stop ibrutinib, for whatever reason, maybe you stop it because the patient needs a procedure and you don't want to have bleeding, then beware of this rebound. The IgM can go up very abruptly. The hemoglobin can go down very abruptly. And depending on how long you hold the drug, you may not be able to get them back into their nadir. So bottom line, avoid drug holds when possible, but sometimes we need to do that because somebody's going to have surgery and this may result in bleeding. So try to titrate your hold period. Speak to your surgeon, make sure you understand how much, risk is involved in terms of bleeding, and titrate the drug, because ibrutinib does predispose to bleeding. Now, there was also this INNOVATE trial, a multinational, multi-center trial where ibrutinib was given with rituximab and compared to placebo plus rituximab. It was really a regulatory trial and heavily criticized because it didn't have a third arm i.e., ibrutinib alone. And so we'll never know really the relative value of adding in rituximab. But let me give you some signs, and hints here. First of all, regardless of genotype, whether they had or hadn't the MYD88 or CXCR4 mutations, patients did better if they got ibrutinib and Rituxan versus Rituxan alone. There were fewer of those VGPRs if you had the CXCR4 mutation, much like I told you, except that this time the addition of Rituxan caused the patients to respond sooner. So they didn't have to wait, many, many months. And it was very similar to what had been seen in the patients that didn't have the CXCR4 mutation. However, when you look at progression, once again, CXCR4 mutated patients progressed earlier. Now, this was a study where they used next generation sequencing to do all their genotyping. And, these MYD88 wild type patients look like they did incredibly well. But I think here the problem is that with next generation sequencing, they were including a lot of MYD88 mutated patients. And these are probably the real wild type ones, the ones that drop off very early. So again, the type of testing platform you use might mislead you in terms of understanding the outcome of these trials. Now I'm going to talk about some of the other drugs. I'm going to focus a lot of my comments on zanubrutinib because we have now comparative phase 3 data against ibrutinib. But you'll see that there are a lot of off-target effects, some of which can be very important in terms of toxicity. And what you see is that zanubrutinib tends to have a relative selectivity against some of these other targets. This is also true in comparison to acalabrutinib versus ibrutinib. And so let me just tell you a little bit about some of these other BTK inhibitors. A word about acalabrutinib. This is a drug given twice daily. It's very, very active. My friend Roger Owen led this trial, and he saw very high rates of activity, just like we saw with ibrutinib. And even at the 2-year mark, when they reported out this study, the progression-free survival curves looked excellent. You can see here that if the patient had no prior therapy, 90% at 2 years had not progressed. If they had prior therapy, it was 82% had not progressed. There were some differences in side effect profile compared to ibrutinib. They did have some headaches at the beginning of the trial, and atrial fibrillation was present in about 5% of all patients, and 28% discontinued therapy with about an average of 2 years of follow-up. Most of them probably because of progression, because when you look at discontinuation due to adverse events, you see that it's only a small minority compared to the total number that discontinued. Now, this is the important ASPEN trial. This was a head-on trial of zanubrutinib versus ibrutinib. It was the first ever head-on trial that was reported in any disease, and it just happened to be Waldenstrom's. And this trial was engineered so that there was 2 arms. Cohort 1 was only MYD88 mutated patients. They could get zanubrutinib 160 twice daily or ibrutinib 420 once daily. And then there was the second arm, cohort 2, where these were patients that had no MYD88 mutation. This was determined by PCR. And here, the patients got the zanubrutinib 160 twice a day. So what did we learn from this trial? What we learned is they're both great drugs, same major response rate across the board. But zanubrutinib treated patients had more of those VGPRs numerically. This didn't reach statistical significance, but numerically there were more. This trial will be updated at ASCO, the American Society of Clinical Oncology meeting, which is coming up in just a few weeks. So we're going to see really what happened to these responses. And the one thing I will tell you from our experience with ibrutinib is that time is a very important element. This trial did not reach statistical significance for its primary endpoint, which was predicated on more VGPRs and CRs for zanubrutinib. And I think the flaw here was the time by which this was meant to be shown was 1 year. It's just too short to show these kind of differences. And so That's why I'm excited about ASCO. I think we're going to learn a lot because now there's a lot more follow-up. What we also learned in this trial is that if you had the CXCR4 mutation, you also saw fewer of those VGPRs, irrespective of what arm you were on. Numerically, there were more VGPRs on the zanubrutinib side. But you can see, again, a difference in both arms in terms of the achievement of those VGPRs. The big news with this trial, and this is the reason why I think the FDA approved this drug, why the EMA has approved this drug, why Health Canada approved this drug, is because of the side effect profile. When you look at the atrial fibrillation events, far fewer with zanubrutinib compared to ibrutinib, so 3% versus 18%. Less diarrhea events, less bleeding events, but conversely, there was more neutropenia. This is when, again, the white blood count becomes decreased in response to the drug, and these patients required more GCSF. But if you notice, no difference in infection signal at all. And so I think it's important to keep in mind that it's, that there is a yin and yang here with these, two drugs. And this is why, it's nice to have them, because you're going to see that there are select patient populations where this could be very important. And I'll go over that in just a second. I do want to also make a comment about the zanubrutinib second arm, the cohort 2. These were, again, patients without MYD88 mutations determined by PCR. And, strangely, or perhaps surprisingly in a good way, was that there were a lot of responses, major responses, VGPRs associated with zanubrutinib alone in this population, which we didn't see with ibrutinib. Now, one little criticism, and that is some of these patients had no bone marrow involvement. Okay. It's possible that with PCR, they could have been missed. And in fact, I know of 2 in this study, 2 out of the 28, that did turn up with repeated genotyping to have the MYD88 mutation. But there were also a lot of other patients here that had a lot of disease, and they, it's unlikely they would have been incorrectly genotyped. And so I think at the end of the day, zanubrutinib does have activity in this patient population, and that distinguishes it from ibrutinib. So one of the questions that I posed to you earlier about areas of controversy is, what BTK inhibitor do you choose and for which patient, now that we have, multiple BTK inhibitors? And I will say right off the bat, ibrutinib, acalabrutinib, and zanubrutinib, they all bind to the same target on BTK. They're covalent binders, meaning that once they bind, they bind. And so when you're thinking about these covalent, these 3, I'm going to focus on these first because I'm going to talk to you about one more drug, pirtobrutinib, that's a non-covalent towards the end of my talk. But among these 3 covalents, there are some things that you can think about when you're, about to choose which BTK inhibitor to use. And the first question that comes up often is convenience and compliance. If you have somebody taking a drug once a day, they're much more likely to be compliant and take it. And that would favor ibrutinib, because especially in certain populations, older patients, for instance, being able to stay compliant means also making it easier to take the drug, and once a day is easier. But there is also data with zanubrutinib. In fact, the FDA and Health Canada approval is that you can give zanubrutinib either 160 twice a day, or you can give it 320 once a day. And there is a phase 2 study where this was looked at. And in fact, to my surprise, when you look at the supplement very carefully, the patients that actually got the drug once a day actually had even less side effects. And that's when, and their major response rate was the same as people getting it 160 twice a day. So there is this latitude for physicians to be able to prescribe it once daily versus twice. I may refer you to the Dr. Trotman paper. It was published in Blood. This was the phase 2 study that occurred before the phase 3 trial, the Aspen trial that I just showed you. Now, if you have somebody who you need a deeper IgM response, for instance, think about the patient who comes in with peripheral neuropathy, who you got to really stomp out that IgM as much as you can and keep it down, you might think about zanubrutinib, because we saw more VGPRs with zanubrutinib. Bing-Neill syndrome, when the disease gets into the brain, most of the data that we have is with ibrutinib. I think in due time we'll see more zanubrutinib data, but that's why we prefer using ibrutinib. If the patient has a history of arrhythmia or is at risk for bleeding, this would be more prudent to use a drug like zanubrutinib because of the lower risk that we saw in the ASPEN trial. But if they are pancytopenic or neutropenic, this would favor ibrutinib. Now, what about somebody with no MYD88 mutation? Well, if they were correctly genotyped, you would consider zanubrutinib because we saw no major drug activity with ibrutinib. We don't have any data on this point with acalabrutinib. If they were intolerant to ibrutinib, we now have data around using zanubrutinib in its place in Waldenstrom's. There is data also with acalabrutinib, but in CLL. And what if somebody became resistant to one of these drugs? Then it would be incorrect to think about just using another one of these covalent BTK inhibitors because they all bind to the same spot, and that's usually where the mutations occur in Waldenstrom. So this is why this new investigational drug called pirtobrutinib, it's investigational, it's not FDA approved or Health Canada approved, is getting a lot of attention these days because it binds to an alternative site on BTK, and it's showing wonderful activity in this disease, in Waldenstrom. Now, if somebody is intolerant, meaning they have side effects, I'm going to give you some of the guidance that's out there. This is a study that was published by us, or presented by us, I should say, at the American Society of Hematology. What we learned here is that if you reduce the dose of drug, and a quarter of the patients in this trial required at least one dose reduction for side effect, you don't penalize the patient. In fact, most of them still maintain their response. So being able to dose reduce provides one avenue for somebody who's intolerant to ibrutinib. The other is, think about a switch over to a different covalent BTK inhibitor. And this was a study presented by Dr. Shadman at last year's European Hematology Association meeting in previously treated patients with different B-cell malignancies, including Waldenstrom's. And the patients could be switched over if they were intolerant to ibrutinib or acalabrutinib. They could get the zanubrutinib either twice daily, and 2/3 did, or once daily, 1/3 did, a little more than 1/3. And so what did we learn in this trial? What we learned is actually that most of those intolerance events, whether they were on ibrutinib or acalabrutinib, did not recur when the switch over to zanubrutinib happened. And this also was very instructive for me looking at atrial fibrillation because they had 10 events which prompted the change to zanubrutinib. Only 1 out of 10 recurred at a lower grade, so it was less intense. And 9 out of 10 patients did not have recurrence of their atrial fibrillation. So I think this sort of intra-patient data to me is very strong because it does show you the differences in these BTK inhibitors in terms of the propensity to cause arrhythmia. In the last few slides, I just want to touch on some of the newer drug options. I want to highlight that we're doing something about CXCR4. There was a study that I published last year in Blood involving this monoclonal antibody ulocuplimab. It actually binds to CXCR4 and it prevents CXCL12 from engaging it. We gave this with ibrutinib to CXCR4 mutated patients. And what did we learn? Well, we learned that we could actually change the behavior of their disease and make these patients look like they had no CXCR4 mutation. In fact, all of them responded. 1/3 of them had a VGPR. Those major responses occurred very quickly. Again, almost all of these patients were treatment naive, where it would have taken 7 months to get to a major response. Here, it was only taking 1.2 months on average. And at 2 years, 90% of the patients were free of progression. So it's a great study because it does show you the feasibility of targeting CXCR4. Pirtobrutinib, the drug I just talked to you about, binds to an alternative site on BTK. When people develop mutations and their disease is progressing on ibrutinib, zanu, or acalabrutinib, it usually occurs here in this cysteine 481 on BTK. So being able to look at an alternative site is makes sense. And so we've done work in our laboratory to show that pirtobrutinib can actually shut down the signaling that mediates the resistance. And more to this point, my good friend and colleague Michael Wang at MD Anderson ran this study called the Bruin study, and he included Waldenstrom patients that had previously gotten one of these covalent BTK inhibitors, and in fact saw very high levels of response. So this is why we're excited about this drug. My colleague Jorge Castillo and Shana Sorosiak at our institution will be running a dedicated pirtobrutinib study in Waldenstrom. But I do see this drug making its way towards FDA approval in view of the aggregate of data that's been already accrued with it in various B-cell malignancies. I want to say one word about venetoclax. This is a BCL2 inhibitor. We just published the paper in JCO. The drug was just added to the NCCN guidelines based on this study. Very active in Waldenstrom patients. These were previously treated patients, heavily pretreated in fact, and we had a major response rate of 80%. Responses occurred even among patients who had already seen a BTK inhibitor and regardless of CXCR4 mutation status. And, the upshot was that the median progression-free survival was 30 months. We only gave it for 2 years. We did see neutropenia in about half of all patients, but the patients in this trial got up to 800 milligrams a day. So by rolling back the dose and giving some of these patients GCSF, we were able to treat the neutropenia. So as I wrap up here, what I'd like to say to you is that, we're excited about these advances because I think they give us an opportunity to rationally individualize treatment based on a patient's genomics. For somebody who has not seen treatment before and needs treatment, we tend to prioritize for mutated patients BTK inhibitors. If they're double mutated and you need a rapid response, we will, of course, do the plasmapheresis if they have severe hyperviscosity. But look here, though. This is the kind of patient that we would probably not use a BTK inhibitor because it takes too long. If they're not in a rapid response, then we might add Rituxan to the BTK inhibitor. And if they have no MYD88 mutation, they're wild type. Before we used to use bendamustine and a proteasome inhibitor. Now we also have zanubrutinib as an option. A few more caveats. If somebody has a high IgM level above 4,000 milligrams per deciliter or 40 grams per liter, be very careful about using Rituxan because you can sometimes induce a hyperviscosity crisis. If the patients have big, lymph nodes or extramedullary disease, we tend to use bendamustine-based therapy. We'll use bendamustine or proteasome inhibitors if they have symptomatic amyloid and consolidate with autotransplant. And I'm often asked, what do you do about somebody who has IgM neuropathy? Well, if it's mild, we'll do Rituxan, but if it's moderate or severe, we'll combine Rituxan with ibrutinib or we'll use bendamustine plus rituximab. And there's still a role for maintenance Rituxan. The STILL study that was done by the Germans alluded to the fact that over 65-year-old patients can benefit with maintenance rituximab. In the relapse refractory setting, much the same thinking, except that after a BTK inhibitor, one can now think about venetoclax as well. And there's a lot more to be learned, of course, and a lot of that learning will be relayed at this year's international workshop on Waldenstrom. It's been in abeyance because of COVID, but we're going forward. And the meeting will be held in Madrid at the end of October. If you want to learn more about this workshop, this is the website. And we're excited because we're going to have 70 speakers from all over the globe coming to this meeting. With that, I think I'm going to stop. And again, thank the WMFC for inviting me to be on this program, and also to Baijin for helping to sponsor this program. I see we already have a couple of questions in the chat box. But I'm going to stop and turn it over to you, Dan, and happy to take any and all questions.
Great. Well, thank you very much, Dr. Treon. That was very enlightening, and you've certainly covered a lot of territory, and I think we're starting to see the benefits of genomic-based treatment coming up in our near future, we hope, for Waldenstrom's here in Canada. So on the couple questions that we've got possibly relating to the non-covalent BTK inhibitors, there is it's a very Canadian thing, the newly launched trial that's now available in Canada for nimtabrutinib. Do you have any comparison data or insights on the differences or similarities between nimtabrutinib and pirtobrutinib?
Yeah, so I'm really excited about nimtabrutinib. We have very little data in Waldenstrom. In fact, only a small number of patients have so far received the drug. Their responses still remain to be clarified. There may be potentially an advantage with nimtabrutinib because it actually silences HCK activity as well. I mentioned to you earlier on that HCK is what turns on BTK. So it may actually have added benefit because of that targeting. But time will tell, when we see the clinical responses to both drugs, what the relative activity is. I would not hold my breath for any, head-on clinical trial anytime soon, because these, the population for treating these patients who have progressed on a covalent BTK inhibitor is relatively small. So I don't think there's going to be much enthusiasm for a head-on trial anytime soon. But Nemto looks very exciting. Pirto looks absolutely outstanding. I'm hoping that we're going to see data rolled out at ASH. I've already seen some of that data, and I'm really excited. I think this is going to be a very important new addition to the armamentarium.
And another one sort of related to the non-covalence. With respect to Bing-Neal syndrome, do you expect any similar CNS penetrance for the other BTK inhibitors, and especially the non-covalent ones?
Yeah, unfortunately, with the non-covalents, we have very, very little information, about the ability to cross the blood-brain barrier. But there's also a theoretical concern too. When you get into non-covalence, to be able to bind to the target, you got to maintain a concentration, a high concentration of drug. Whereas covalents, once they bind, they stick. It's like chewing gum, once it's there, it's there. Non-covalents, on the other hand, their binding affinity is very much dependent on the concentration of drug. And so you might remember this, back from your chemistry days, that there is this sort of affinity, but it's very much dependent on sort of the concentration of drug that's around. So in theory, covalents have an advantage over non-covalents because of this ability to, once they stick, they stick. And when you're thinking about, drug getting into the central nervous system, one has to be careful because, the concentration of drug drops off rapidly. In fact, we did the study with ibrutinib, and only 3% of the ibrutinib that's in circulation actually is in the brain space that, circulates in the cerebral spinal fluid. So a very small amount, but that small amount is enough to shut off BTK. You're able to still meet that threshold because it's a covalent drug. With non-covalents, it'll be interesting. Can we get enough drug in there, and will there be enough drug concentration in there to shut down BTK? Time will tell. We'll just have to see what the trials show us, and I'm sure trials will happen that will lead us in that direction.
Great. Thank you for that. You mentioned IgM rebound. Does that apply to the other BTK inhibitors as well as ibrutinib?
Yes. Yes. I mean, I will tell you it hasn't been studied formally, but the expectation would be the same.
Okay. I guess there's a question on the chat. Maybe you could address it, just about watch and wait and how it applies to Waldenstrom's.
Yeah, thank you for that. I think this is a very good question. You know, Jan Waldenstrom used to say, let well do, meaning that if the patient, you know, doesn't need therapy, don't intervene. And it was at a time that we had very, you know, toxic therapies, not a very effective therapies. As we have moved into this, you know, modern era, um, you know, the time to which you start therapy is starting to change. You know, we you know are you know more apt these days to start earlier, you know, to treat patients than let them fall off the cliff first and then, you know, try to grab them. But it's a fine line, and I would just say to the individual that asked that question that it's very individualized. You know, at what point you want, you know, you need to start therapy. If at every visit you see somebody's hemoglobin is going down and their IgM is going up, and they're just becoming, you know, fatigued and just can't do the things that they used to do, well, even beyond the guidelines that we have, you know, a lot of clinicians will start therapy. And with BTK inhibitors, it's a lot easier to do because overall the safety profile is pretty good. But if you think about, you know, some of the side effects that can come with some of these drugs, there has to be some sort of, you know, balance. And this is why, you know, you know, in answering respectively, you know, respectfully answering the individual's question, it really comes down to the patient. You know, is it really time to treat? Do they really meet guidelines? Is treatment more likely than not to improve their quality of life? Those are the sort of things that we would take into account.
Okay, great, thanks. Okay. One other question in the background. Can you say a few words about lab tests? In particular, are there some where the results need to be interpreted with caution because of Waldenstrom's, where Waldenstrom sort of changes the what you might expect from a lab test?
Yeah, that's also a loaded question. It's a good one. You know, I'll tell you I'll just pull this one out of my hat, just you know, to share with you. Um, when you see Waldenstrom patients, often their cholesterol levels are very low. Um, when you treat them, when you treat Waldenstrom patients and their IgMs go down, their cholesterols go up. When they start progressing, their cholesterol levels go back down. And you know, this is a observation that we made. We've published this, and to us, this seemed like maybe there was a relationship between cholesterol dependence for the tumor versus potentially some interference in the assay. And I got to say, to this day, I don't know the right answer, but I do want to say that it is possible that because of the IgM, that sometimes, you know, labs can be distorted. This is one of those examples. You know, I think, you know, most labs tend to be reliable. The IgM can sometimes be off if somebody has a cryoglobulin. When, you know, the time that it comes out of your body and you take it to the lab, if the sample gets cold enough, the IgM will precipitate and, you know, the IgM may be misread. So I would caution people around that. And then I would also caution people that serum viscosity these days, you know, is not reliable. Ever since we went to the digital era and we're using machines to do the, you know, serum viscosity calculations, they become unreliable. So in the old days when it was all done manually, you could count on them. But once, you know, we've gone to digital viscometry, no longer are they reliable. I hope that you know answers a wonderful question, but it's you know, it's just, many facets of the way we look at labs.
No, I appreciate the answer. I think it behooves us all to do our background education on them. A question about trials and who gets admitted, Bing Neel patients in particular. What is the reasoning for often excluding Bing Neel patients from trials?
Yeah, that's a good one. I think in general, there is a concern about the efficacy of a drug when you're dealing with central nervous system lymphomas. And it's really not to penalize a patient, because when you have central nervous system involvement, often the disease is rampant and you don't want to put somebody on an experimental therapy. That being said, I think sometimes it's way to the disadvantage of the patient. So what you do is you create these high-risk studies, that are dedicated to a particular phenomenon. So, we have a trial. We actually had a trial that we were just about to open with ibrutinib and venetoclax, looking at the two drugs together. We already know that ibrutinib is very active with Bing Neel syndrome. There's data now to suggest that venetoclax is also active, that you can actually see CNS penetration. But that trial, abruptly had to stop, and so we never got to open up the arm, for Bing Neel patients. So we won't know the answer, about combining those two drugs together. But I will tell you, there is a lot of enthusiasm now within our community to study Bing Neel, as a distinct entity within Waldenstrom, and to do prospective trials. The same with neuropathy. There's an acalabrutinib Rituxan study now dedicated only for IgM neuropathy. So, you're starting to see these specific morbidities being looked at, in prospective trials.
Okay. I think we've got time maybe for one more question.
Sure.
And if we can discuss something a little bit more relevant to the COVID era. The question is about interactions, I guess, between ibrutinib, Paxlovid, and recommendations of stopping one when taking the other, and how to deal with that.
Yeah, no, again, this really comes down to the individual events, surrounding a patient getting COVID. If the patient is demonstrating, a response to vaccination, we sort of categorize those patients different than somebody who has had no response to the vaccine. And here in the United States, our preference is to give Evusheld. This is a monoclonal antibody. In somebody who has not responded to the vaccine, we'll actually prioritize them, even getting it prophylactically. Of course, if you get COVID, this would be one of our immediate responses, is to give Evusheld, because we just don't want to be caught in this dilemma of, having to stop one drug, to start another, because you can get this rebound very, very quickly.
All right. Okay, well, thank you very much for that. So I guess to summarize then our evening together, I'd first like to thank Professor Treon for his engaging and very informative presentation, and for sharing insights on WM research. I think we're all very confident that the future of Waldenstrom's research is in good hands with you and your team. Now I'm at this point, I'm speaking on behalf of Cam, the chair of the board. Unfortunately, we seem to have lost him. So at this point, I would like to thank all of the doctors who've taken the time to attend this presentation. Hopefully you've learned a little bit more to help you treat and understand all of us WMers. And I do have a few more thanks that are in order. None of this could have happened without the assistance and input of Chris Patterson, who's the administrative director of the Bing Center. So our thanks to him. In addition, we would like to thank the people at Beijing, without whose support this presentation would not have been possible through an educational grant from them. The IWMF has graciously assisted in arranging the technical infrastructure we've used today. It's been wonderful to work with, and thank you very much to the IWMF. And lastly, thank you to all of my fellow volunteers at the WMFC. Your help was greatly appreciated.